We have hit the last session of the day, and we have three esteemed visitors from Michigan Medicine here. The first one is Bree Commons. She's an intern guest services senior supervisor at Michigan Medicine. In her role, she has been the driving force behind several pivotal initiatives for her department, but the one she is most passionate about is her work with autism kits. She pioneered getting these kits at most entrances to the hospital and was just awarded $10,000 from the Mock Golf Classic to grow the initiative. So play golf, people. Bree's vision for support of neurodivergent patients and families includes the expansion into clinical areas, inpatient units, and the adult hospital. Bree received her Bachelor of Science in Biopsychology, Cognition, and Neuroscience from the University of Michigan, and her Master of Business Administration from Siena Heights University. We also have Paige Huta. Did I do? All right, Paige Huta, it's getting late. I don't know if I can read this. Graduated with her master's degree in occupational therapy from Eastern Michigan University in 2015. She currently works on the inpatient rehabilitation unit at Children's Hospital. She is passionate about neurodiversity, affirming care, and partnering with families and children to achieve meaningful goals. Paige brought a neurodiversity affirming approach to treatment in her outpatient role and is eager to continue bringing this important lens in an inpatient setting. She loves incorporating children's special interests into the play-based activities to make occupational therapy sessions a fun and engaging experience. And this one is really small. And last but not least, we have Dr. Barbara Felt. She is a developmental behavioral pediatrician at the University of Michigan. After graduating from Wayne State's Medical School, she completed pediatrics residency at Johns Hopkins Hospital in Baltimore, then a fellowship in developmental behavioral pediatrics at Case Western in Cleveland, and her clinical interests include child sleep problems, elimination of disorders, and ADHD, and advocating for the needs of individuals with neurodevelopmental concerns. Actually, a fun fact, Dr. Felt was the first one to diagnose my son, so that's awesome that she's here full circle. Okay, take it away. Oh, I have one more? Oh, I have one more. I'm so
that's okay.
sorry. No, you have to be introduced. If I could see it. Jessamine, boy, that is small. Jessamine Ressler Merlander is the lead process improvement specialist with the Michigan Medicine Children's and Women's Hospital in Ann Arbor. In her role, she integrates health system priorities into unit work, including around health equity and trauma-informed care and family integrated care, as well as prevention of hospital-acquired conditions. She also supports the Project on Equity in Adolescent and Child Health, PEACH, as a quality improvement specialist. Previously, Jessamine was director of the NICU Innovation at March of Dimes, helping newborn ICU patients improve the patient and family experience, implement standards, and create and disseminate best practices in neonatal family-centered care. Jessamine received her Master of Public Health from the University of North Carolina.
And I went to Michigan State. Go Green. Well, hi, everybody. Thanks for sticking with us through the second day last session. Paige and Bree and Dr. Felt and I are really excited to be here and just share about our work and also to get your feedback and ideas as we move forward through this process. So we all work in the hospital. And there are a lot of people who have been part of this work. And so I just want to highlight how many people have been involved in sort of some of the different roles that are included. So we talked with lots and lots of families. Families are sort of at the front line of what families and patients need when they are dealing with any sort of challenge within the healthcare system. And that goes doubly for patients who are neurodivergent. We talked with lots of clinicians because they are experiencing some of the same things that families are, and they're a really important part of the care team. We talked with lots of support staff because people like Bree are the first people who, when you come into the hospital, who you engage with. And we talked with community members who have insight about what resources are available and where there are gaps. We have our contact information at the end if you want to ask us any other questions later or share our information, please do. Our approach was really sort of a all teach, all learn idea so that we could really understand what was going on in our system and figure out how to make it better. So this is just a brief outline of how much work has been happening, and I think this probably only represents about a quarter of what is really going on. But since the early 2000s, there has been work around supporting neurodivergent patients better in our healthcare system. This initial video that's mentioned here was created in partnership with a patient who still is active in a lot of our patient and family advisory committees to help clinic staff understand just what exactly they should be doing in terms of communication. And that was a very powerful video for a lot of people in our system. In the 2015s, Bree and a team got together to figure out how to reduce some of the stress and help neurodivergent kids engage with the healthcare system. She's going to talk a lot more about that later. In the 2020s, we have a lot of different kind of disparate things going on in different units across the hospital that are homegrown because we have a staff member who went, oh, we really are missing the mark here, let's make something. And that's great, but it's not coordinated. And I also want to give a shout out that there's a partial day program starting, which ends up getting a lot of kids who are neurodivergent and have severe behavioral challenges. And we also just got a grant for a music therapy space that is, Paige can probably talk a lot more about the occupational health side of things, but is really designed to help kids who are neurodivergent in the hospital have an actual physical space to go to, because we don't have that right now. The Mott Mental Health Committee is sort of a group that just gets together to talk about what's going on and share best practices. And one theme that kept coming up was that we don't do a very good job of trauma-informed care or developmental care. And when we thought about that, we started talking about what would it look like if we were to fix that? What are the gaps? What's our current state? And my background in process improvement is to do things like talk about what are the gaps, measure them, understand our current state, and then help people implement solutions. So all the things we're going to talk about today are pieces of how that was generated just from conversations in our mental health committee. So the real driving question for us was, how do we link efforts? Because we need to do a better job of serving patients and families. And we have these silos where we have people who are doing clinical interactions, like Paige and Dr. Felt, and they're doing an amazing job, but it's uneven across the system. We heard over and over again that we need better peer support. And we also have a lot of tools that are homegrown or that are best practices from somewhere else that we may or may not be using at any given time. So we wanted to figure out how do we do a better job and put this all together. So we're each going to talk about some work that's being done, and we have a lot of quotes that we're going to share as well to sort of kick off each section because we have so many great quotes from patients and families and community members and clinicians who are really helping us do this work. So I'm going to hand it off to Paige. Oh, you have your own?
I do.
Great.
So here are just some of the quotes that Jessamine collected during some of our information gathering with patients and families. And then I'll go into my clinical interactions more on a micro level with patients every day. So I'm an occupational therapist at Mott. I primarily work on the 12th floor on the inpatient rehab unit. So I typically see children after some sort of surgery or traumatic brain injury, spinal cord injury, or other trauma. And so as part of the OT team, I also see patients with feeding difficulties or failure to thrive. So within that, I see a lot of neurodivergent patients. And then on top of that, there's also a lot of medical trauma that has happened. So these kids really need a specific approach to be successful and to get through their hospital stay, which can sometimes be 6 weeks plus, where we're seeing them every day. So there are 6 specific things that I always look at when I see a patient, and especially a neurodivergent patient, and what I try and communicate to the medical team and to the other therapists of the best way that we can serve this patient. So I really see my role I provide occupational therapy, but I also want to look at through this neurodiversity affirming lens at the patient and communicate to the medical team what they need in the hospital. So the first thing that I always do with a patient is presume competence. So that is just the idea that all patients are capable of learning, connection, and relationships. And in the hospital setting, one way to presume competence is to always assume that the patient can understand what you're saying to them. So we see patients in the ICU. On the rehab floor, I see a lot of patients that are non-speaking, and we always just have to presume that they know what we are talking about and what they need. So an example of a patient that I've had recently was a non-speaking autistic 5-year-old with cerebral palsy who had a selective dorsal rhizotomy. That's a surgery that we see a lot on the inpatient rehab unit. So this surgery specifically significantly reduces lower extremity muscle tone. So this patient went from being able to walk independently to now not being able to walk at all. And was seen by some of the medical staff as having negative behaviors because they're yelling when the staff comes into the room. They're really in distress all the time. So my assumptions when beginning therapy with this patient is that they're aware that their body is different, of course, and that they don't know why. And that could lead to some well-meaning medical staff or even families saying, what's going on? Their behavior is so awful now. So I begin every session and encourage families to begin every day with saying, your legs are not working how they used to before surgery. You're in the hospital to get stronger, and we're here to help you get better. Versus only talking to the parents or assuming that this patient doesn't have the capability to understand this. And if the patient was an AAC user, we would program this into their device and model it so then they can also make comments about how they're feeling. And along those lines, the second thing that I will always do with all of my neurodivergent patients is honor all forms of communication. So in an inpatient OT session, this could look like bringing in their AAC device or using sign language. It also means taking a further look at any of those perceived negative behaviors and really digging deeper. And we'll talk about that as we keep going. So one other thing, sorry, back on the last slide. It's okay, it's just one word. So interoception is something that I really look at a lot. And that's how the body senses and interprets signals from its internal organs and systems. And this is often a forgotten sensory system. And we know that it is often different. Autistic adults have told us that they perceive body senses differently. So in the inpatient setting, the thing that comes up most frequently is pain management. So sometimes neurodivergent patients may have an increased pain tolerance and not notice that something's hurting until it's an emergency. So this is something, if I have discovered this about a patient, that I will communicate with the medical team that we really need to be on top of their pain management, even if they're not verbally telling us that they are in pain. And sometimes they may have a lower pain threshold and their pain level also needs to be validated and honored. So this is something that I'll observe in my sessions and also report back. So they know to keep an eye if a post-surgical patient is reporting zero pain or if they may have heightened sensation. So another big thing that I do in my OT sessions and that I'll communicate with the nursing staff about is reducing verbal demands. So in the hospital, it can often seem to, especially a pediatric patient, that they have no control over what's going on throughout their day. So everything, including my sessions, are scheduled, and they hear demands all day long, from opening their mouth to get a temperature during vitals, or to hearing lock your brakes every time they get in their wheelchair. And these small demands can add up over time, especially to our neurodivergent patients, and particularly our autistic patients with PDA. So no matter the diagnosis, I will use declarative language to lessen these verbal demands. So instead of saying lock your brakes, if this patient is verbal, I will just casually say, I wonder what else we need to do before we get in your chair safely. Or I will make myself the center instead of them, and I'll say, oh my gosh, do you see what I almost forgot? Don't get me in trouble. So that usually goes over a lot better than being a nag, I have found. And then with some of my patients, I mostly rely on a skilled environmental setup to lessen the verbal demands. So on the inpatient rehab unit, a lot of times I'll be working on just sitting balance. So instead of telling a patient over and over, reach for the beanbag, tuck your chin, I will simply just place it where I want them to reach, and I'll adjust the distance based on their response, so we can still meet all of our goals. One other thing that I'm always looking at is sensory processing. So we touched on it with interoception, but all of the other sensory systems as well. So honoring and understanding the sensory processing needs is a really huge piece of creating a neurodiversity affirming environment inpatient. Being in the hospital is a really challenging sensory environment for all kids, neurotypical and neurodivergent. There's new noises, fluorescent lights, busy environments, the monitors are beeping. So additionally, on the rehab unit, as we briefly discussed before, patients have new physical functioning levels, so they may not be able to walk as they used to or move around. So this can drastically change the way that they are processing proprioceptive and vestibular input, since they aren't able to do the same activities that they were before. So for example, if we have an autistic child who previously met their sensory needs independently through jumping on the trampoline or going on their swing throughout the day, and now they don't have the core or the leg strength to do so, part of my job as an OT is to find new ways to meet that need when they go home and in the hospital environment. So for that child, that may look like swinging in a sheet in their room, rolling on a ball, compression socks to replace the sensation they had prior to surgery in their legs. And then the last thing that I am always thinking about when I work with a patient is their motor planning. So we know that it's very common for autistic children and adults to have dyspraxia. And when receiving care, it's something that needs to be accommodated. So our patients may not be able to coordinate their bodies in a successful way to complete a toilet transfer or something similar. So some ways we worked on this on the inpatient rehab unit is breaking down that task into one small movement at a time, providing proprioceptive feedback during the task, or adding a gestalt or a rhyme about the steps, so it makes it easier for them.
I feel like I know a lot more about occupational therapy now. Thank you. And there's so much that goes into this, right? Like that's one clinical interaction for one patient, and I think that's our goal, is to be able to use a lot of these concepts throughout how everybody's able to interact, and we need to set up our system to help people do that. So one thing that our mental health committee did was decide to just talk to as many families as we could and learn about what's really going on and what do you need from us, because we recognized that we were missing the mark as an institution. And this idea around isolation was really important. So something that families said over and over again was, we don't know what we don't know, and wherever we are in our journey, we really need help, and we want to hear help from people who have been through the journey. And that's what a peer support group is designed to do. So we got together a small group of people, and Quinlan Davis was really instrumental in this. He could not be here today, but he's going to share some of his words along with Ebony Babs-Brown and me. We sort of helped get this off the ground to figure out what would it look like to have a peer support group based on that family feedback. We partnered with the Office of Patient Experience, which is what Quinlan represents. And we had so many people who were so interested in this and so engaged. And I think it really speaks to people want the opportunity to participate and help, and that this gave them a forum to do that. We had our first session in January. We had 5 families, which felt like a big win. We were hoping for 3. Kind of like today, we were like, maybe we'll get 5 people. And look, y'all are like doubling that. Our next session is at the end of April, and if anybody wants more information or to participate or to learn more or to attend, there's Quinlan's information. So Quinlan and his wife Kendra are also parents of 2 kids who have autism, and they are going to share in their own words about their journey and also about what Quinlan's role is in this work.
Hello, everyone. My name is Kendra Davis.
I am Quinlan Davis out of the Office of Patient Experience.
And we are the parents of 2 wonderful boys who happen to have autism. And at the beginning of our journey, when we first were in the process of gaining diagnosis under the staff with University of Michigan Hospital, we both went through a very strenuous grief process. First, we felt sad, we felt denial, we felt anger, and we had to ultimately come to the point of acceptance. And that was a very long journey for us, only to turn around and also have our youngest to be diagnosed with autism. And it felt as if the grief journey started all over again, even though we had previous experience just with autism diagnosing in general. We believe that having a peer mentoring group or even a peer mentor individual to follow us along the journey of the initial steps of getting diagnosed, also knowing what to do afterwards, and having that mental, physical, and emotional support would have been amazing, especially for us who we didn't have too much knowledge of autism. We didn't have too much knowledge of what it would look like for our lives and also our child's life, and then later on our youngest as well. So having that peer mentor support would have been amazing and beneficial in so many ways.
We were able to partner with staff members and my administration and get family feedback. We found out that there was a lot of high interest and high engagement for individuals in the neurodivergent community. We want to explore some of the processes that the healthcare community go through with the neurodivergent individuals, children, and families, and also partner with individuals outside of Michigan medicine to see what kind of needs that we may go through. Like, what does it take to get support in the school systems and beyond, like working with law enforcement and individuals that have that may not know much about the neurodivergent community. We know peer support groups helps with community-based needs. It helps decrease anxiety amongst groups of certain areas. It also helps increase the outcomes of some of the areas, as well as being able to have someone be able to help you on this journey, because this is a long journey and this is a lifelong journey. So you have an individual who's been there before and will take you step by step about what some of the things that they experienced in their child's journey.
And we know that every experience and journey is not the same, but just having someone that has gone through before, step by step, walk with you through the process, we see that is something that would be truly beneficial to families, not only going through an autism diagnosis and journey for the first time, but multiple thereafter. Thank you for listening.
So now we come to, what do we do when we have all this information from families and community and we know what we want the interactions to look like? And so one thing that we decided we could do was sort of look around and be like, what's out there? What's actually happening? I want to give a shout out to Dr. Letitia Carter-Blanks, who is a pediatrician at the Northville U of M clinic. She's an advanced trainee in developmental care. She has, in her own practice, identified a lot of needs and started to address them in her own way, which is just phenomenal. She's kind of famous for, she just has a stack of stationery and it's got basically a letter on it that says, this kid needs testing, and I know what my rights are as a parent, and my pediatrician says that you as a school have to take care of this. And she hands those out kind of like candy. It's great, and really helps parents learn how to start to advocate for their kids with schools. She does a lot of other advocacy and connects families to support services. And she's going to be piloting some of our sensory kits that Bree's going to talk about in a little bit. Dr. Joanna Quigley is an outpatient psychiatrist who has been fundamental in starting a partial hospitalization program. And why that is important is because many kids with autism or who are neurodivergent end up really needing additional mental health services, or if they're having a hard time with school and they end up needing a lot of additional help. So this program is really addressing a gap in care because we have hospitalization for kids who are in a serious mental health crisis, and we have outpatient care, but there wasn't anything within the U of M system to help those kids. And so this is really a focus for kids who are seriously at risk, particularly with OCD and mood disorders. So it's not always kids who have autism or who are neurodivergent, but there's enough overlap that I think this work really, it's important to represent it here. That will open in early summer 2025, so stay tuned. And then there's the inpatient work in Mott Hospital. So Paige and Ebony and I have worked to figure out what's going on in different units and how do we make sure that everybody can use it all consistently. So we have started some convening meetings, which is interesting because people will be like, well, I have this. And someone will go, well, I have this. And then we look at them and then they're like, oh, I want that. No, I want that. And so they're trying to figure out like what's sort of like at the heart of the material that they want to use, and then how do we leverage that so that everybody uses it? Because how many of you have ever like been to the doctor and had a different experience from time to time? Right? Like it's amazing how the variation that happens. And it's the same on an inpatient side for a kid who's hospitalized. So what we want is that every time a kid comes in and we know that they're autistic, we want to be able to address their comfort care plan, to make sure that their communication preferences are honored. And we want to do that consistently across shifts in a day, but also when they transfer from unit to unit. So we're doing a pretty intense current state analysis. And then we're going to look at how we can strengthen those processes across different roles, because it's not just nurses and doctors. I'm going to hand it off to Bree, who's going to talk about some sensory kits.
So I just wanted to start off by kind of telling the story of how I got involved in this, because it kind of was like a small thing that turned into a big thing, and now something I'm very passionate about. But so we had autism kits in our department when I first started, and that was back in like 2017. But then when I took a supervisor role in like 2022, I had a trainer come to me because we have this like list for all of our training, because when you come in the hospital, our staff anybody can ask us a question. And so we have lots of resources. We're kind of like a go-to for any question someone would have. Like we'll try to figure it out. So we have lots of like training and resources to educate our staff. And there was autism kits on the checklist, and he was like, we don't have those. And I told him, I'm like, well, we should. And so then I go out to the desk and I'm like rummaging through everything and realize like we don't have these anymore. And I'm like, I don't know what happened to them. So somehow I think during COVID, we had a lot of different staffing changes and leadership changes. And obviously it was a very stressful like time for everybody and a lot of how things were going to go. So what was crazy though is so once I realized we didn't have them, I was trying to figure out how to get them. And so the people that were in charge of that previously did not work there anymore. So it literally took me 2 years to get these autism kits implemented again. Because once I figured out there wasn't like people there, then it was like the issue of where's the money coming from? Because my department, we don't like make money, we just cost money. So they're like, we don't want to like pay for that. And not that it wasn't important. So then I'm like, had to use all my resources. And then I got connected with Mott administration, and they're like, well, yeah, like we want to get these implemented again. It's a great like resource. So I got an initial funding of $1,000, I think from the Mott annual fund, to just get them out there. And so Chris could not be here today, but he's on vacation with his wife and daughter currently in Tennessee. But he is one reason why I got so much more passionate about it, because his daughter is autistic and nonverbal, and he's also was like my lead. So we've gotten really close, and I can see like how it's like affected him and being a father. And he was telling me a story about, his wife taking her to the dentist, and that would be such an experience that we would not like think would be a big deal or could be very stressful. I mean, as a kid it can be, but like if she doesn't understand like why they're doing the work in her mouth or how to communicate with her. Luckily that day it went like very well, but it's just kind of given me a lot of insight and like realized my lack of education until I came into this position and working at the hospital. And then also educating my staff. So like that's like one vision I have, is to kind of educate our staff, because we're guest services, but we're also part of DPSS. So officers will go in and work with patients, so they could be neurodivergent or autistic or have lots of other different things that you have to change your approach and how you deal with them. And then sometimes being an officer like can seem a little like more negative if you're bringing them in, and that's not how we want that interaction to be. We want it to be more positive and educate, and not go to like being a negative thing. Like how can we talk, or how can we phrase things differently to make it a more positive interaction? And then also telling my staff, because being in the hospital is a very scary place and stressful. Families don't want to be there, patients don't want to be there. So these autism kits, even, I guess I might want to change the name, but like these kids can also be for just general, like every kid coming in because they're like don't want to be there, or it's stressful, or what they're here for, or families. I also want to expand it into the adult side, because it's not just kids that are dealing with this too. So right now I have them at all the entrances, and luckily Justin's now my partner. We both got awarded the $10,000 to expand.
Another silo. We each wrote a grant.
We did, yeah. So once I got the $1,000, then they told us we could get more money from the Malt Golf Classic, and then they said that there was two proposals, and I was like, oh, someone else is doing this? But it's been really helpful because now I have a partner. But also I got feedback from, so like Chris and I had other staff within GSS that have had experience with autistic children, or that they've had them. And so they're the ones that I reached out to, because I felt like I was a little more ignorant, and I'm also not a medical professional, but I haven't had to deal with it on a personal level. So they're the ones that gave me ideas for different things that we can have in the kits that would be good for all like ages. So they're the ones like I worked with to then get that implemented, and who I hope to continue to work with to like expand on that. And the thing I was like, as everyone was talking, I do think like education with the staff is also very important. Because I realized I didn't have it before coming here, and now since I've had it, I see it a lot more. And like I know, like how you were talking with your patients and stuff, that would be helpful information that if our staff learned, because we are the first, like the face when you come into the hospital. Just because we're not medical professionals doesn't mean that we couldn't like learn tips and stuff and how to make their experience at the hospital more positive. So those are just kind of the things I'm hoping to, use this money for to do better, and then I could see it, be something that we are working on for many years to come.
Barb?
So I'm Barb Felt in developmental behavioral pediatrics, and I'm sitting here just reflecting on the amazing amount of work that's happened, particularly on the inpatient side. And I think my vision as an outpatient provider primarily has always been to see sort of the integration of that, the ambulatory setting. The diversity of the clinics is quite significant on the outpatient side. And the uniformity, I think, could go a long way to improving our patients' experiences. I think about the families that I see who need procedures and really can struggle with how to get that done. Even a simple blood draw coming into, and we are lucky now to have child life at least two of the at Mott and at least one or two of the outpatient settings, but sometimes the hours are not as long as we'd like them to be. Many of my patients need a sleep study. And getting child life for that group can be taxing because it can be hard for one person who's very passionate in child life to be many places at once. Or patients who need to come in for a surgical procedure. And I think I've just been astounded at the PACU staff and the degree to which they go to try to prepare families and do visits with families ahead of time so that the kids can come in, maybe through a separate entrance, not through the hustle and bustle of the main halls of the hospital. And so I think that while the ambulatory setting needs a lot of work, I think that already I've seen improvements that have really come as a consequence of what's happened on the inpatient side. So hearing about what has been done, I think we're really interested in hearing from you all about what the priorities might be. And I know that it's not a big group, but I'm wondering what it's sort of what your interest areas are. How many of you are family members of an individual with a neurodiverse condition? And how many of you are kind of staff members? Yeah? Okay. And how about community members? I guess we all are that, aren't we? Yeah. And how about clinicians? Yeah, great. So I'd like to really open the floor for comments, and I'm going to be taking some notes because, again, it's really important to us to hear from you about what the priorities are. You can see that already the silos, we're trying to break those down, but how to prioritize the next best steps would be great to hear your feedback from. And I don't know if
We have, yeah, you can shout it out. We got a microphone, but you have Post-its too if you don't want to talk.
Hello, my name is Denise Layton and I work for the library. I don't know, it's interesting what you were saying about the ambulatory side of things. I don't know, is that like the emergency side of things? Is that what you mean?
So that would be like any of the outpatient clinics. So Letitia
okay.
Carter Blanks is a general pediatrician working at Northville Center. We in developmental behavioral peds work at Mott, but just in the outpatient, we're not up on the floors. So it could be emergency room, it could be these clinics that are distal from Mott or clinics within Mott.
Blood draw clinics, anytime you go to a lab, anytime you go to a family medicine doctor, anytime you don't have to be admitted to the hospital.
Okay, well, this is for what it's worth, but recently I had to go to Mott Emergency with some friends, and the entrance there is just starkly different from the other side of Mott, right? Like the other side of Mott is just like beautiful and like, you're walking in, so nice. And then the emergency side is just like really harsh in terms of lighting, colors, everything that's happening there. I know we were talking about the entrance experience and like how that's such a important part of like user experience any kind of way. I do a lot of user experience work at the library, so I was thinking about the touch point of the journey, you know, like the entrance as your first opportunity and touch point to relate to people. So yeah, that's just a really random thought as you're collecting
great
really
point.
random thoughts.
Yeah.
You said you came, oh, it doesn't work. Okay. You said you came through Is it like the doors when you came in, or because like I also know our staff, we have to go through the weapons detection system in the EDs. Was that like a part of the negative,
just
or
like
just
the
when you walk in?
Just the emergency side of things. It's like directly opposite.
It's a crumbling parking garage entrance is what and it feels like a cave.
Yeah.
That's true.
Great point, Denise. Thank you.
I also think that the emergency room is really busy, and for some kids with sensory issues. It's a lot of things coming at them at once. So if they could have just a separate area that would be more calming would be awesome.
They are currently working, so like it seems like the seating area is smaller, but they are working on right now construction and believe it is like a triage area. So bigger than what it was before to be able to get patients back, I think, sooner and having like a separate space than what they did. But it's currently under construction right now. But I think hopefully that will help with that a little bit.
Hi, my name is Ashley Everett. I'm a clinical psychologist in CAP, so I just work with students there. But I'm on the Eating Issues Network, where we have folks from the Comprehensive Eating Disorder program at Mott, so that's what I'm most familiar with at Mott. But I was curious if you know if there's been any work there, because I think we're seeing more like ARFID, which overlaps a lot with neurodivergence care there, if there's been any thought of how to make that more neurodivergent friendly.
So that's a really good. So we work in the same space as those clinics, and I know that we're having discussions on the developmental behavioral side where we are doing evaluations for neurodiversity and other eating disorder or gender issues clinics in order to improve the communication between those groups. And so I know in our group, our DBP side, we're doing quarterly meetings in order to facilitate the appropriate referrals, because people come in through different doors, but just to really have a view of the whole person so so all of their needs can be taken care of or helped comprehensively is really, I think, a goal for the families that we serve.
And then on the inpatient side, when a child is coming in with an ARFID diagnosis, they're now automatically getting an occupational therapy referral where we'll do a sensory profile and we will give our recommendations from the sensory side of things, including like not force feeding. We do some very, especially with our younger kids, very general play-based, sensory-based feeding approaches. So that's something new just in the last few months that we've started, is that OT referral when a patient is admitted with ARFID. We typically won't see them in the emergency room unless they're like under 2 and they're here for weight loss or failure to thrive. But we are frequently seeing those patients with ARFID on the floors now and have received feedback that it's been a helpful piece of the puzzle.
I have one from online. I would love for prioritization to be made when it comes to building relationships with and including inpatient learning specialists or hospital school teachers in a more aspects of patient care. I'm a hospital school program researcher, and my literature reviews have revealed a huge disconnect between the work of the clinical staff and hospital school teachers. Teachers not receiving patient referrals, not being invited to in-round, not being asked for updates regarding hospitalized student progress, etc.
That is a wonderful comment.
Yes.
I think that the structure that the school educators provide on the inpatient side is so important to keeping individuals kind of up with their work, but also creating a structure within the day that really helps to mirror what people will be going back to at home. It's a very helpful comment.
And we'd love your contact information, whoever put that in the chat, because you should join our committee.
I second that.
This is really helpful and really great questions. Thank you all for being here and for what you do and how you're helping us be better.
Any more questions? No more questions? Oh.
Hi, I'm Kate Hagedorn. It is weird to hear your voice in the speaker. Okay. I am a parent of a neurodiverse individual and also a psychologist with grad students in Michigan Medicine. Mostly, I just wanted to say thank you for all that you're doing. I'm so glad that you're meeting regularly and working on these issues. I think they're really important. So mostly, I'm just saying keep up the good work, and then also just wanted to second the child life extended hours thing. I recently had to bring my kid to the ER for stitches, and of course it was like 9 p.m. And so the person was like, would you like a child life specialist to come and help you while you get these stitches? And she said, absolutely, yes. And then she was like, oh, my child said yes. And then the nurse was like, sorry, they just left. So that was a bummer. I mean, we got through it, but it was like so nice to have that offered. It was a bummer to have it taken away, but I certainly understand that they need to go home too. So just want to second that support for that program. And I think figuring out ways, I certainly understand that because there's so many ambulatory offices, it's hard to have consistency, but I think working towards that is a really wonderful goal. I don't really have, I mean, you all are experts on this and are doing really good work, but I'm curious about like, if there's, one thing, like, is there a question that everyone could just get asked when they come in, either by support staffs or whatever? Like, do you have any sensory needs that we should know about or something like that? Like just one simple change that could be made consistently throughout the clinics that again is going to be small, but just as one that could be helpful and informative for, your next practices, but also like that could be, just to see how can we create this conformity throughout the processes. So thank you.
I would add that for adult care too. Yeah.
We do a script actually when you come into the hospital where we health screen. I could actually even see us just asking additional questions for patients and families or even visitors. Like, is anyone in your party have any sensory needs that we could then connect them with a resource? Like we could then tell my staff to, call someone or a child life to then come out and like meet them. We do get sometimes heads up for special cases. I know like when some patients are going to surgery and stuff, we get emails. So we're like a part of security, but we're guest services supervision, and then we have security supervision, and we work closely. So there's like some that can't ride in elevators, and we'll coordinate escorts up the stairs with them. But we do normally get a heads up from like social work and stuff too. So when that happens, we do have more of a plan in place. But I think that questions was something we could easily add to our scripts to help with that too. So great idea. Thank you.
And I want to add one more thing to your comment about the hours. So we talk about the hospital as being a 24/7 operation, and it's not, to your point. I'm going to put on I'm going to be very calm and collected about this. But what I will say is that in a resource-tight environment, which is what our hospital is, hearing from families and patients and people who have experienced the system is very powerful. We have gotten this far because we talked to families and got their feedback and then took it back to administration. And I think that's really important, that the administration is willing to listen, but it is better if it comes from you all. And we do need more child life, and we do need more OTs, and we do need more training and more resources. And in this environment right now, that's really hard, and it's scary to think about what we might not have. And so I think the more that we can advocate for the sort of patient-centered care that really matters. And I think one thing that we all know is that if we do a good job with kids who are nonverbal or kids who have severe behavioral challenges or who are really worried and anxious and neurodiverse, we're going to do a good job with everybody. And right now, we're not hitting the mark. And so this is a great opportunity for us to think about how is this an entry to just do better all across. So thank you.